I think we'll go ahead and get started. Today we have Dr. Hohmeier here from the University of Tennessee Health Science Center. He's an associate professor and director of community affairs in the Department of Clinical Pharmacy and Translational Science there. He has an extensive background in pharmacy and practice-based and implementation science research, including postgraduate residency, training in community pharmacy, credentials in Lean Six Sigma and change leadership, attending the University of Pennsylvania's Implementation Science Institute. Currently, his specific areas of research are in clinical service implementation in community pharmacy settings, medication therapy management, and innovation clinical pharmacy practice models. He has served as PI, co-PI in over 15 grant-funded projects, most of which explore expanded roles of pharmacists and pharmacy technicians in community pharmacy to increase patient care activities, as vaccinations, medication, therapy management, and other clinical services. To date, he has authored over 90 papers, published in peer-reviewed journals, and 10 textbook chapters. So with that, I will turn that over to you, Dr. Hohmeier. You can share your presentation. Welcome.
Well, thank you so much, Sydney, and thanks again for the invitation to present here today. I'm so grateful for the opportunity to speak with all of you. I know this is a diverse group of individuals who are joining us here today, and I'm excited to speak with all of you, especially coming out of hopefully a very relaxing weekend. I know most, if not all of you, are healthcare providers who may have had to work on the holiday, but hopefully you at least got some rest and relaxation somewhere throughout the Thanksgiving Day weekend. So anyways, a few housekeeping items here to share. We've got some claiming credit information on the screen. This will be shared in the notes section or the chat section of the Zoom meeting as well. So please make note of that there if this is moving too quick for you on the slides. But getting to the heart of our talk here today, what I'd like to discuss really is community pharmacy as a public health and primary care destination, which I think most of us probably realize it's where we're heading. I think there's probably consensus there. How quickly we're heading there is probably up for debate. And some of you who are more veteran out there may have heard this talk in various iterations from other speakers over the past 30 years, because we've been heading here for a long time. But my take-home message, hopefully at the end of this, that you'll get is that we're very, very close. And I know, again, we've been saying that for a while, but we really, really are. So there's a good news message in all of what we're going to talk about today. I do want to disclose that we've received some funding from Merck for an ongoing project here at the University of Tennessee Health Science Center. A few questions for all of you to contemplate as we head into the lecture today. Which of the following is a factor driving change in the community pharmacy practice model? And I hope you all don't mind, but for the interest of time, I'm going to move kind of quick through some of these intro ones. We'll slow down at the end because I'll pull up these questions again. Which of the following represents a needed skill gap in the existing pharmacy workforce? Which of the following is the primary means by which prescribers and community pharmacists collaborate on patient care? And then lastly, describe the primary driver for delegation of pharmacist duties to pharmacy technicians. Our objectives here today will be to describe what's driving change in community pharmacy practice and changing the pharmacy practice model, to differentiate between existing and future pharmacist skill sets for needs of the population, describe the role of pharmacy technology in advancing patient care, and then lastly, to describe the role of the pharmacy technician in task shifting and how that relates really to everything we're talking about here today. But before I get started, I want to give a little bit more information about myself. So I'm in Nashville, Tennessee right now. I am not musically inclined. I actually was not born here or raised here. I actually came from Cleveland, Ohio, on the sunny shores of Lake Erie. For all of those joining us today, I'm sure you have at some point visited Cleveland, a popular tourist destination because of our clear waters, white sand beaches, and palm trees, which of course is a big lie. I'm just trying to see who's paying attention. This is actually Cleveland, Ohio. We are affectionately known as the Mistake on the Lake. Our river has caught on fire once before. We are fully, truly a Rust Belt city, but one that I'm very proud of is everybody from Cleveland. We are very proud of our city. And this is one of my favorite, and I think a very beautiful picture of the downtown area, because it represents so much of what Cleveland is, and that is our skyline, which is huge, but it is historic. We've got this old bridge that crosses the Cuyahoga River, which is the river that caught on fire, which used to transport steel over a railroad on that bridge. And then we've got a really historic bridge there, which has our two guardians of the bridge, which is why our baseball team is now called the Cleveland Guardians. They're two large statues, which actually you can see maybe behind me right here is a picture of one of the guardians. So let's talk about our topic today in three major points. What is driving community pharmacy practice change? What are some examples, and what's the future? That's really what we're going to talk about. To begin with, what's causing the change? What's the headwinds that we're heading into in community pharmacy practice? And really, there's a handful of things that are really contributing to this change, and it's in multiple directions. So this isn't just a pharmacy pushing phenomenon. This is a lot of different variables all playing together to create some kind of synergy around this practice change. There are changes in public perception and the demand of healthcare, which favor community pharmacy, even if outright they're not saying we want more community pharmacy services. Public perceptions are shifting such that there is a demand for a change in healthcare. There's a changing reimbursement landscape, specifically declining reimbursement for prescription product and increasing opportunities for value-based reimbursement, such as medication adherence and patient care outcomes. This is really pushing hard on the chain pharmacies, which are desperate for new and diverse revenue models beyond the prescription product. And so that's important too, because we need motivated stakeholders on the pharmacy ownership and leadership side. There's a shift in pharmacy training and credentialing. Of course, the Pharm.D has been required as a degree for licensure since about mid-2000s. But even beyond that, new credentials, postgraduate training, our training and education continues to evolve and improve. We're highly accessible. This is now officially published paper that cites 90% of Americans live within 5 miles of a pharmacy. That was sort of a nebulously claimed item before a close neighbor of you all in Virginia, Lucas Ehrenbrock over at Pittsburgh, published on just about a year ago on that is true geospatially. 90% of Americans live within 5 miles of a pharmacy. Very important citation for all of your papers. I would write that down. And then lastly, another Behrenbrock publication here, Americans frequent pharmacies almost 2 times more frequently than prescriber offices. So we've got access, we've got this changing public perception of what is healthcare, and then we've got motivation for really pharmacy leaders, chain and pharmacy owners to embrace change. And I love to point to this Deloitte 2018 study to really demonstrate what I mean by public perceptions are changing. If you see here in this sample, 46% want a convenient location, almost half of the sample. Reputation, personality, convenient hours, and the price are all really important, and they all favor community pharmacy practice. Notice only 16% of that sample say that medical school or training of the provider is what matters in what they're looking for in healthcare. So again, you're seeing the patient really looking for something different from what they've looked for before, all favoring community pharmacy practice. We're going to talk about 3 pillars of community pharmacy-based practice change today. The first is behavior change techniques. I see that as being a big pillar. Next is integration of technology, and then finally, pharmacy technician task shifting. I think all three of these things are what's going to be the foundation pillars for what pharmacy practice will be probably for the next few decades at least. And all of them, by the way, are synergized, if you want to say, or catalyzed by the collaborative practice agreement. I think without the CPA, we're really just looking at what we've been doing historically, which is to provide medications, which is an important task for sure, but we're limited by our legal and regulatory restrictions. The CPA opens things up, depending on the state and the CPA practice law, opens things up in a huge way so that we're essentially a mid-level practitioner. And that's certainly how things are in Tennessee. The CPA, of course, for those of you unfamiliar with it, is a legal agreement. It can allow for prescription authority, ordering laboratory tests. It formalizes a process for communication with an overseeing clinician. And then it's available in most states in the US now to varying degrees, and that's a whole other topic. I would visit NASPA, NASPA, for more information about the CPA if you're not familiar with that document. But essentially, the CPA is the power tool which allows a nurse practitioner or a PA to operate under a licensed physician. We have that same ability in most states in the country at this point, again, to varying degrees, but it is such an important tool because it allows us to do those things that we all, as pharmacists, want to do for our patients in ways we can't just do based on state board regs. And here you'll see a CDC citation on here basically saying, look, pharmacists are important public health providers, and the CPA is a catalyst for engaging pharmacists in a greater degree for public and population health. And again, this is a CDC document. So you see from the federal side, the government side, we're seeing bigger support for what a pharmacist can and should do for the US population. So anyways, let's talk a little bit more about this first pillar, or behavior change techniques. And what do I mean by this? Behavior change techniques in pharmacy. Well, if you're looking at the general definition, these are ways that we can assist a patient to engage in healthy behaviors to improve or prevent diseases or health conditions. But why does this matter for pharmacy, right? Aren't we the medication experts in therapeutics, right? We just have to know what the guideline is and a little bit about each of the drugs that a patient could take. But in reality, we see what patients need is more than that. It includes medication non-adherence, vaccine hesitancy, medication misuse or abuse, diet or lifestyle, and the need for deep prescribing. So although it's great and it's our foundation, it's truly the center of what we are as pharmacists is being therapeutic experts. By itself, as a competency, it does not meet these other areas. And in fact, what's core to all of these other areas, the string that ties them together, is patient behavior. And so you're getting now into your your theories of behavior change and motivational interviewing, things like that. But I think the future pharmacist, future and current pharmacist, really needs to have a good handle on motivating for behavior change, understanding what causes patients to engage in certain behaviors. Because to meet some of these things, which by the way are tied to payment, to be able to address some of these things in these rectangles, we need to know more than just the right drugs and when to use the right drugs. We need to know how to engage with patients. These are human beings. These aren't computers. It's not just enough to tell them the right thing to take and assume they'll take it. We need to be able to engage with them to co-create plans, to do shared decision-making, and the like. So I want to briefly talk about one of the studies that we've wrapped up here at the University of Tennessee, but we're still kind of working through the data and then applying lessons learned. And the study here is facilitating pharmacist assertiveness in promoting pneumococcal vaccination among high-risk adults. And this was a simulation-based training program that we did for Walgreens in Memphis and in Nashville, Tennessee. So it's our west side of the state and central Tennessee as well. The objective here was to improve pneumonia vaccine uptake through better recommendations by pharmacists and really through using behavior change theories. And what we created was this quality recommendation pathway. which leaned heavily on the trans-theoretical model or the stages of change and motivational interviewing. And what the idea behind this was we wanted to make an assertive, presumptive recommendation for the pneumonia vaccine, one that does not initially invite conversation. Something like this: you're due for your pneumonia vaccine. Would you mind stepping aside? We'll go ahead and get that drawn up for you. There shouldn't be a charge today. Or, there's a $5 copay or whatever it might be, which is different from, can I talk to you about the pneumonia vaccine today? Does X, Y, and Z. It's kind of popular. Patients your age, we like to recommend it. What do you think about that? So hopefully in hearing those two examples, you can see what the difference between those two recommendations are. And the evidence shows it's the presumptive, assertive recommendation that leads to more yeses than the one that sounds a little bit more wishy-washy, like you're not really confident that this is what the patient needs. So anyways, you begin with that assertive recommendation, and then from there, if there is vaccine hesitancy, we work through the rest of the stages of what's here, the pharmacist patient care process overlaid on top of that, to figure out what is causing that hesitancy. That's what you collect to assess what's underlying that hesitancy using your knowledge of behavior change, then to make a plan. So maybe we'll follow up in 2 weeks after I've done some education with the patient on what pneumonia is and how frequent it is in patients that age. And then I'm going to make a note in my computer system to remind the patient in 2 weeks to see where they're at in their stages of change. And we'll document that for follow-up. So anyways, we found that with this training, pharmacist self-efficacy improved across the 6 items that we measured in a survey, which preceded and then followed the training. And then between the 2 groups, control and intervention, there was a 25% difference in vaccination rates between those 2 groups, although this did not reach significance, which gets me to my lessons learned. Behavior change training is unique and challenging. It's not just as simple as, you provide them some training and some times to practice it. It really is not core to what our training has been. And so there needs to be a lot of follow-up. And so what we're going to do in the future, and what we have actually begun to do, is change our simulation that was part of the training from being on campus in our multi-million-dollar facility, which was, nice and fancy and shiny. Instead, we're going to do in situ training. And this was a recommendation from our trainees after the project. We got some feedback over survey. They really felt more comfortable with the simulation being done at their pharmacy, which is what's called in situ training, right? So we're going to do the simulations there with virtual Zoom technology and have them practice behavior change techniques in a place they already feel comfortable. Our training to practice ratio was 2 to 1. They spent twice as much time in online training and live training as they did practicing it. We want to flip that. Really condense the training, really condense the readings, and then have them practice and practice and practice and practice. And then lastly, to train the trainer. And this was a recommendation from one of our Walgreens division leads. He said, just have your folks that you train go back to their stores and then train the pharmacists and technicians there, who may or may not soak in all the stuff that was taught, but the person doing the training is likely going to be better knowledgeable on the behavior change techniques because they did that training. And so there's good evidence to back that up. We haven't studied it specifically yet, but our plans are to do so in the future. So our future directions here, we're going to work with experts in motivational interviewing training to better design our behavior change interventions. We saw a signal that this is likely important information for pharmacists to improve vaccine recommendations. But we sort of did this on a shoestring budget. We're going to really pull in folks who do this for a living and make a more robust project out of this. And so we've got an R34 right now to basically do this. And we're going to do it in making recommendations for patients to not co-use opioids and alcohol. So same basic framework, but instead of vaccines, this is to sort of counsel against co-use of opioids and alcohol. We're also going to explore and describe patient-reported goals, because that's really important to motivating the patient. So we want to better understand, how do we motivate the patient? What are their goals going into treatment? And so we've got a couple projects there ongoing, one with, again, opioid use disorder, and another one with HPV vaccines. And so literally our whole goal here is just to better understand how patients are making decisions, what's motivating their decisions and their behaviors. And then lastly, we're working to identify pharmacist impact in other areas, primary medication non-adherence being one of them, and again, going back to opioid use disorder. But all of these tie back to that bigger pillar of behavior change techniques, which hopefully you can kind of see where I'm going with this. It may feel like something foreign to pharmacy, but when you really get down to it, now more than ever, it's a really important skill set we need to be preparing our pharmacists to be able to handle. Next, we're going to talk about integration of technology and how important that is for the change of the practice model. Really, our next two pillars are not things that pharmacists needs training or skills in or competencies on. These are things that will support the pharmacist in this new practice model. And of course, technology is a really obvious example of how do we advance the pharmacy practice model. And so one of the things I'd like to talk about a little bit is communication as an example of this. The majority of collaboration between pharmacists and other providers today, literally still in 2022, almost 2023, is over fax and telephone. It's inefficient, it's prone to errors, it's difficult to track. For those of you in practice who have been in practice, it's the bane of your existence, right? Because it ties you up, it distracts you. And there's so many other options that are available. It's really kind of silly that still today we're using those as our primary means to communicate with other professionals, to collaborate across professions. So I'd like to share another project. This one, back a little bit, we wrapped this up in 2015. I'm sorry, 2017, we wrapped this one up. And this was the use of a health information exchange to facilitate transitions of care in a community pharmacy in East Tennessee. For those of you who don't know what a health information exchange is, it's basically a central hub from which that hub collects information from hospitals, primary care providers, specialists, laboratories, and pharmacies, and houses it so that it can be then pulled into other pharmacies, other software system for hospitals or health systems or pharmacies, or made available for an online web portal to be accessed. It's not a magic box, right? And very important. It's a central hub to store things. And if an organization has the funds and the priorities to do so, they can use that data in really great ways, like seamlessly pulling it into an electronic health record, right? But for those like the pharmacy we were working with, who may not have those kind of funds, at least the information was available on a web portal that you could log into separately with different credentials, which is a pain, but you could still access the information from which to make decisions. Now, would it be great if that information from every health information exchange was pulled into every pharmacy across the United States of America? Yes. Will we get there someday? I hope so. But we're not there right now. In fact, at the time of this study, there was nothing done on health information exchanges and pharmacies and what an HIE could do for a community pharmacy. So that's what we wanted to really understand, was what was the potential here. And so what we found across a very small sample of patients in this transitions of care study facilitated by the HIE was that the HIE actually was able to help the pharmacist find at least one discordant medication across all 25 of their transitions of care patients. I'm sorry, 100% had a discordant medication. 60% had HIE use. So it was something that pharmacists preferred to use in their transitions of care at the independent pharmacy. The majority of patients, HIE access was useful for. Community pharmacists, after being able to access the HIE, were also confident in their abilities to perform medication reconciliation with the use of the HIE within workflow, even though it wasn't a very seamless workflow. As I mentioned, this was a separate login with separate credentials, something that probably had to change every few months, right? But they still preferred it because the expansion in data access for them was useful and was worth the extra time burden. And then lastly, the average time spent per patient for HIE facilitated transitions of care was 21 minutes. And one of the biggest deliverables we got out of this study was what you see as the figure 2 on your right-hand side of the slide. And this was something that we developed through a Think Aloud protocol. The pharmacists basically talking out loud as they were using the HIE as part of their pharmacy services. And so we were able to map out what does it look like when a pharmacist is using the HIE within pharmacy workflow. And I'll tell you why that's important in a second for our future work. But just in general, it's important for the profession because as we study the use of these external data hubs of information, we need to know how pharmacists are using them so we can make it more efficient. And the more efficient it is, the more likely it's going to be scaled. And that's ultimately what we're going for here. What also was neat in this project was we found that although we wanted the pharmacists to use the HIE for transitions of care, the pharmacists who started using it for TOC ended up also using it for resolving drug utilization reviews and patient questions too, because they had all of a sudden this whole new world at their fingertips from which they could assess and make new decisions from, which they never really had before. Or if they wanted it, they'd have to wait for a call back from a physician or a nurse at the office that they called. So what are our next steps here? Well, we're taking this information and we're actually under a grant from NCPDP Foundation working to directly tie a pharmacy software system, ironically the same pharmacy, to a medical office, a larger medical office in their the same region that they're in Knoxville, Tennessee. And we're going to do that using HL7 FHIR technology, which just know that means that's the most up-to-date standard in health information data sharing language. So it's the highest level, and it's using the pharmacist e-care plan. Again, not enough time to talk about pharmacist e-care plan, but just know that that's a standardized means for pharmacists to document pharmacy services. So the dream here, what does this all mean together, is that within workflow, in the pharmacy software, without using a separate portal, the pharmacist should be able to provide transitions of care services for a medical provider and communicate with a medical provider bidirectionally in the software itself. No telephone calls, no faxes, no separate web portals. So we're grateful for NCPDP Foundation for supporting that research. More to come on that. We're still working through the build out right now with CareCloud, who's the EHR vendor that we're working with. Okay, our last pillar then is pharmacy technician task shifting. This has been historically a controversial topic, although I've seen it less so more recently. But certainly in some areas, it's still very controversial. I'll tell you in Ohio, where I hail from, where my license, primary license is still held, not a super popular topic still. In Tennessee, it wasn't popular maybe 10 years ago. It's becoming more accepted today. I think there's a culture shift that has to happen here. And in fact, I'll kind of share with you some of the evidence is really pointing there. That when pharmacist perceptions and pharmacy perceptions, so the entire pharmacy personnel, including leadership and technicians, when their perception of tech or technician duties shifts, the service, I mean, it implements so much quicker than previously. But all of that to say that the idea of task shifting to a pharmacy technician, what I'll propose to you is this isn't a maybe nice thing to have, or if all things were possible, I'd love for this. I can say pretty confidently at this point, if we do not task shift, at least in community pharmacy, we will not be able to do the things that we want to do and that we've been publishing on for 3 or 4 decades at this point. So what does that mean then? Task shifting. Well, that's entrusting specific responsibilities to another member of a healthcare team that has adequate training and comfort to meet the expectations of the delegating provider and patient. What this can lead to is increased access to care and better patient care outcomes. And this isn't just coming from studies in the United States, and it's not just coming from studies in pharmacy. This is actually the biggest base of data here is in the developing world, where there literally aren't healthcare providers in entire regions of other countries. And what they're trying to train up is lay professionals to be able to provide really basic and rudimentary healthcare services. And so, no, would it be great if we had a cardiothoracic surgeon in every area of the United States or in South America? Sure. Is that practical? It's not. So what's the next best step? And that's the framework I'd like you to all think about as we talk about this topic here. So pharmacy technician task shifting in particular improves medication safety. It improves patient outcomes, specifically in prevention, treatment, and medication use. And there's a variety of areas where task shifting has been important and has really done tremendous things, including administrative roles. So having the technician help to manage, to set schedules, to sort inventory, to work through all the Medicare regulatory burdens that we're tasked with, through to things like collecting patient information. And actually right now, PTCB, the Pharmacy Technician Certification Board, has a credential in med rec for pharmacy technicians. That's something that historically we've kind of thought of as being a professional pharmacist service. Well, you know, again, it would be great if every pharmacist could do the med rec, but in reality, where we have limited resources, a well-trained pharmacy technician does good work in that area. But it expands also to billing and documentation, immunization, point of care testing, medication therapy management, and something that we'll talk about, which is technician product verification. So for those of you who have never heard of product verification, this is also called Tech Check Tech. It's the idea, and you'll kind of have to follow along on the diagram if you're unfamiliar with pharmacy workflow, but it's the idea of having a technician engage in verifying that the right product was filled, in medication distribution workflow. Essentially, what happens in a typical community pharmacy workflow is a prescription is presented. It is then entered into the computer system, typically by a technician. It's then verified by a pharmacist that it was entered correctly and that it's the right drug for the patient. It then goes to a product fill station where a technician then takes that data verified label and fills, based on the label, a medication, typically with barcode or some other kind of technology to ensure that the right thing is filled. And then it goes back to the pharmacist again to verify that the right product was filled. That last stage is what we are talking about. Instead of having a pharmacist verify that the right pill is in the bottle or that the right insulin was selected, instead that's done by a trained and experienced pharmacy technician. This requires state-specific regulatory approval, unlike things like MTM roles where you can just sort of delegate that because it's a role of the pharmacist, and based on that, you're able to delegate your duties. This stage in particular is not something a pharmacist can just delegate. This thing has to be regulatorily approved. And so each board of pharmacy needs to have either change the language, as Idaho did, basically to say that all things a pharmacist can do can be delegated, or more commonly, specifically place language in the board rules to say that a technician can verify prescription products for accuracy. But I'll tell you, after multiple states and multiple years and multiple studies, we have consistently seen the same three things: an increase in pharmacist time, decreased medication errors, and increased clinical services delivered in these tech product verification models. So again, it's been very controversial, less so now than it has been in the past, but depending on the pharmacist that you talk to or the pharmacy technician even, you may get varying levels of pushback. But the data, the objective data is clear that this does all the things that we really truly want. And if you were just to say, here's this blinded intervention, which increases pharmacist time, reduces med errors, and increases clinical services delivered, would you take this blinded intervention? Most people would say yes, until you said, well, it's tech check tech or tech product verification. Then you may hear, well, I don't know, that wouldn't work for the technicians at my pharmacy, right? So how it's implemented is a little bit more challenging, but the model itself is sound. I want to highlight a couple of quotes from some of our research here in Tennessee. One is from this independent pharmacy technician who says, I wanted more responsibilities, and I feel like this tech check tech program has been able to give it to me. And then this other quote from another pharmacy technician, for me personally, I like the challenge. I like something new. I've enjoyed TPV or tech check tech. I feel more confident in my role as a product verification technician. Also want to share with you that task shifting, especially in medication therapy management, is it's a huge area for potential research, and certainly for those of you in practice, if you're not engaging at a high level in verification of, or I'm sorry, in delegation of MTM roles and responsibilities to your tech team, please just attempt to do so. Maybe with your most senior technician, maybe with the one who's just most gung-ho about pharmacy in general and taking care of patients. But I think you'll be surprised pleasantly at what a difference it makes. And there's been several projects where I've seen this true, but the one in particular I want to highlight is one here that's featured in this table, where basically we took the top quartile of pharmacies who were performing MTM, so at the highest rates of MTM service. So we took those pharmacies in Tennessee, specifically at a supermarket pharmacy chain in the state, and we did triangulation of data collection, which basically means we looked at this from different ways. We did journals that the technicians filled out, we observed, we conducted interviews, and we tried to figure out what were these pharmacies doing that led them to be doing MTM at such a high degree. And what we found was that there's these clinical support skills and responsibilities and non-clinical ones, which were delegated to the technicians at a very high level. And that was really the key to them doing MTM at such a high level at those pharmacies. And I think it's an important thing to know, it's both of these things together, the clinical and the non-clinical support skills. So clinically, the technicians were enrolling patients into the MTM service. They were preparing the patient chart before the pharmacist even walked into that room to take care of the patient for the MTM. They were doing the documentation, the billing, all stuff that you kind of assume that a high-level technician should do. But they were also, the entire team was engaged in telephone triage. So if a patient calls to the pharmacy and says, I want to talk to the pharmacist, it was, hey, well, the pharmacist is actually with a patient right now. Is there something I can do for you? I'm a certified pharmacy technician. And you know what? Something like, at least the majority, probably 80 or 90% of the time, the patient was able to get that thing resolved with the technician instead of just handing it over to the pharmacist. They really worked to protect that pharmacist's time. They also took on team leadership functions and administrative responsibilities, all to free up the pharmacist's time. So again, in a nutshell, this is my thesis, if you will, that the future of pharmacy practice, all the new things that you hear reported in Pharmacy Today and published in JAFA and RSAP, I really truly believe they hinge on these three pillars: behavior change techniques, integration of technology, and pharmacy task shifting. But I do want to add one more thing, maybe we'll call this fuel for the fire. And that's that emerging payment models really are needed to be embraced to help to push this along. And I want to highlight something that was just published last month in JAFA from the small team that we've got here working on payment models at Tennessee and community pharmacy. And what we did was we worked with a Memphis-based community pharmacy who created a membership model of pharmacy. And he wasn't the first one to do this, and he's not the only one. But we haven't had it rigorously assessed in the past. And what we're able to do is to use the REAIM framework and some more rigorous analysis to look at, let's cut into this membership model. Let's open it up and see what's working and why it's working. And I'm not saying this is going to be the solution, but it's going to be looking at new ways of how do we bring revenue into the pharmacy that's going to lead to us improving pharmacy practice. So it may be shared savings, it may be quality measures, it may be this membership pharmacy model. Likely it's going to be a combination of all of these and not the same things in every area of the country. So it's just important to be familiar with the new and emerging payment models that bring revenue into the pharmacy, because those are going to be the things that fuel all the other great services being piloted in pharmacies today. So what pharmacies need to change practice? Well, improve pharmacist behavior change skill set, I think through certainly Pharm.D training, but also CE offerings like the one here today. And then, of course, micro-credentialing and other credentials for practicing pharmacists too. I think we need to reduce waste and increase patient data access through improved communication. That's got to be a priority. And then advanced pharmacy technician roles to free up pharmacist time. And then lastly, really to work to improve payment models to incentivize patient care. So which of the following is a factor driving change in the community pharmacy practice model? Increasing desire of patients for convenience over credentials. Patients want convenience. They're shopping for healthcare now. And that may sound frustrating for some of us, but what it really is saying that patients are being bigger stakeholders in their health. And that's a good thing for pharmacy. Which of the following represents a needed skill that is a gap right now for the pharmacist workforce, and that's behavior change techniques. What's the primary means by which prescribers and pharmacists communicate right now? I'm ashamed to say it's fax machine. That's just where we're at. And then lastly, describe the primary driver for delegation of pharmacist duties to pharmacy technicians. It's an increased direct patient care service offerings. With that, I'll go through some final housekeeping slides here. Again, this will be in the chat, and we can maybe open things up to the group for questions.
I did post everything in the chat, so if there's any issues, I will also add my email. Feel free to email me if you guys have issues with that. And if anybody in the classroom has questions too, feel free to use. There's a few mics around and ask those, and then whoever on Zoom.
Sydney, is it okay if I drop the share screen for this part?
Yes, that would be great. And we have somebody in the classroom who's going to use one of the mics to ask a question.
Wonderful.
On. You have to hold it. Oh, yeah. I have to push this.
Nope.
Can you hear that?
You can hear me?
on the Zoom?
Okay. So you talked a little bit about like opioid use disorder treatment in this setting. Will you talk about that a little bit more?
Yeah, so really broadly, a lot of what a community pharmacist's role right now can be in high-risk opioid behavior or opioid use disorder is in motivating for behavior change. This isn't just let's go prescribe buprenorphine, although I think that's a role for the pharmacist in the future. We can't do that today. So I think where we need to see more research is in how can we motivate patients that we know are either at risk for opioid use disorder, we know are maybe engaging in high risk behaviors that can lead to opioid use disorder. How do we engage them in conversation and either get them to community resources that they might need, back to the prescriber, or how do we make sure they're not using the opioid in a way that's going to cause morbidity or mortality? And the one example I cited is our R34 that we're working on around alcohol co-use with opioids. So these are patients who are on an opioid prescription for some legitimate reason, but also are using alcohol recreationally. And basically the CDC's point of view on this is there is no safe amount of that, because we literally do not have enough data to know at what threshold a patient have enough respiratory depression to die or to become hospitalized. And so we know it's happening. We know it's happening to a high degree. But how do you have that conversation, right? We teach it on a slide in pharmacy school, and we say patients shouldn't co-use alcohol and opioids. But I bet you if you talk to community pharmacists out in practice, many of them are not providing that counseling point, or those that are kind of do it knowing that patients are going to do their own thing anyways. So how do we provide the counseling in a way that patients really are hearing what we're saying, that they understand the risk, and that hopefully they mitigate that risk by changing their behavior?
Thank you so much, Dr. Hohmeier, for such a thought-provoking presentation.
Sorry, I don't think the mic was working, so she was using the mic here in the classroom. But I think
sorry. Go ahead.
I'm sorry about that.
Go ahead.
Try it again.
Is it okay if no one else has a question, right? I don't want to steal the show. Okay. So the only reason I asked was because even yesterday I had a patient come to me as a pharmacist and want to know how to take buprenorphine after using opioids and then not using opioids for 2 weeks. And it would have just been really helpful to have like an algorithm, because I just had to refer them to the emergency room, and I just have to hope that they went. And so I think like having training is really important. And like, I don't know, I just wanted to validate that. I saw it yesterday, so I know it's important.
Yeah, and thanks for bringing that up. It's please continue to have that conversation, because I think there's such a misunderstanding of the tough spot a community pharmacist is in around that entire spectrum, from prescription opioid being dispensed to a naive patient all the way through to medications for opioid use disorder. We are between such a rock and a hard place. On the one hand, we are unfunded regulatory enforcers, specifically through the DEA, but also through boards of pharmacy. And on the other hand, we have to be patient advocates. And it is really challenging, because no matter what, it almost feels like somebody is upset. And so for that reason, there's been really unclear guidance, even in the most recent guidelines released by CDC, around what a community pharmacist can do in a really important touch point, right? And that's the point that's really gotten forgotten, is there's this reliance, well, the prescribers need to do a better job. And yeah, that's true. But if you go back to one of my first slides, who sees the patient way more often, right? Who's seeing that patient continue to decline from prescription to prescription? Who's in that patient's community? It's the community pharmacist. But we've got no toolbox. We've got no tools and no toolbox to be able to work through those patients. And they're very high demanding patients too, right? They're a emotional burden on the pharmacist. And I don't mean this in a negative way. It's really an objective fact. These patient interactions are very difficult to navigate in general, even if you have really good guidance, and we don't even have that. So what you get is this emotional burnout and eventually compassion fatigue, which is something we're trying to work on increasing awareness on. But there's sometimes this, well, pharmacists don't care. That's really a superficial perception from folks who are outside the pharmacy profession. It's not that pharmacists don't care or that we're overly rule followers. It's that there's this regulatory need, and then there's this compassion fatigue. And when those two things meet, it's felt externally as the pharmacists don't really want to help the patient. We do. We're not in a situation right now where we're able to, and that can be facilitated, I believe, through more research and awareness.
I'm going to cut in really quick and just say, if anybody needs to leave, we are kind of hitting our time. Feel free to do that, but also hang around if you still have questions. But I just wanted to go ahead and thank you, Dr. Hohmeier, on behalf of CPPI for speaking. And just say that before everybody leaves, but then I'll let people continue to ask questions if anybody still has that. So.
Well, I'm sure you all can grab my email